Thank you for that kind introduction. So let's get on to it. I know some of you are a little bit mentally fatigued, but I'll try to make this brief and a little bit, try to make breast ultrasound a little bit interesting if I could. So the other way. So we hear Dr. Suarez speak about screening mammography. And I would say right off the bat that multiple studies have validated screening mammography. So there's the only one that has been shown to reduce deaths from breast cancer, and that is a scientific fact. There are a lot of people who try to say that that is not a scientific fact by looking at statistics, as she alluded to, but the most learned bodies in the world agree that screening mammography saves lives, right? Nevertheless, as she has also said, mammography is not perfect, right? So it doesn't pick up 100% of cancers in 100% of the cases. There's some instances where mammography may actually not be effective in certain situations. So overall, the sensitivity, that's basically a term that means how effective is mammography is around 85% for picking up breast cancer on average. So some breast lesions are not very visible on certain mammograms for certain patients. So let's look at this example here. These are two different patients. This one has predominantly fatty breasts, or adipose tissue is a medical term for fatty breasts. So this breast is predominantly dark. It's mostly fat. And this breast is a little bit brighter. You have a lot of white areas on the mammogram, and that is normal dense breast tissue, or fibrocystic changes, or fibrous tissue, many different terms for it. Look how easy it is to pick up the cancer in this case. This case, you can't really see it. So you could understand how a radiologist whose job is to look at these images, sometimes hundreds of these images for the week, will possibly miss a cancer in this case, right? So mammogram is not very good for picking up breast cancer in dense breast tissue. It's still effective, but not as effective as in a fatty breast. So the sensitivity of mammograms in a dense breast is somewhere around 47 to 64%. And there's another thing that a lot of people are not aware of, is that people with dense breast tissue actually have a greater chance of developing breast cancer. So if you think about it logically, the tissue in the breast that produces the milk, that are the ductal and the glandular elements that produces the milk when you're breastfeeding, that is the tissue that changes into cancer. So you could jump to a logical conclusion. If you have more of that tissue, then you're going to have a greater chance of having cancer. If you have less of that tissue, you're going to have a less chance. So that's why somebody with a fatty replaced breast has a lower chance of developing cancer than a person who has an extremely dense breast. So that is the perfect storm. So somebody who has very dense breasts, they have an increased chance of having cancer, and the best tool for looking at cancer is not very good in those patients. So that's where other things come into play. I have to remember to put this in the correct direction. So what is ultrasound imaging of the breast? Ultrasound, or like how in Trinidad we like to say ultrasong, S-O-N-G, sonography is is an imaging modality or a type of a radiological investigation for us to look at the internal structures of the breast. And we're basically using sound waves, so that's where the sound comes, but of high frequency sound waves that you can't hear. It is non-invasive, meaning you don't have to do anything invasive, you don't have to press too hard, you don't have to squeeze, you don't have to get a choke, you don't have to get anything. It's non-invasive, and it can diagnose as well as treat conditions, and we'll see that later how it can do that. And even though mammograms are low-dose x-rays, they still have a very small potential to actually cause harm. Ultrasound does not have any of those types of x-rays, so therefore the chance of it causing harm to the human is not possible. So how is the procedure performed? Well, you basically lie on your back on the examination table, and usually your abdomen is covered, so you're not totally exposed, and usually it's one breast at a time is exposed. You may be asked to raise your arm and put it behind your head. You don't need to like a mammogram, you know how they'll tell you not to wear deodorant on the day itself, except you don't need to do any of that for the ultrasound. So please wear deodorant. Yeah, it's yeah. A warm gel is applied, and at the Cancer Society, we actually we've been using something even different. We aside from using warm, so you normally see when you're doing this motion to get the gel onto the patient, they flinch because they're expecting ice cold gel, but we actually warm it. And what we also use, we use a cream, so it's called a lotion, and it's easy to wipe off. It's easy for the probe to slide, that sort of thing. And they even have some now with aloe vera and these kind of things in it. So things are evolving. So it's not that thick, sticky gel that we often use. That's very cool. So we've been evolving from that. And this is the transducer, and we basically move it all around the breast. It might look totally random to you, but we actually have a method to look at the breast and make sure we cover all the areas, because if we don't cover all the areas, then we're not adequately evaluating the breast properly. The transducer, which is this instrument here, is moved back and forth. Sometimes we might ask the patient, do you feel a lump anywhere? Do you feel anything strange? And they might say, yeah, doc, and point to a certain area. Then we put our fingers and feel if we could feel it, and try to interrogate that area a little bit closer with the ultrasound probe to see if we can see an abnormality. When the examination is complete, you'll just be given tissue to wipe off the breast. And you'll hear us talking about 12 o'clock and 1 o'clock, etc. We just divide the breast into these clock positions so that if we see an abnormality, we can say where it is, the distance from the nipple, the depth from the skin, so we could almost triangulate where it is. So let's say we have to follow that up in 6 months, we know exactly where to go and look. If we have to do a biopsy, we know exactly where it is. All right, so what does the equipment look like? Basically, you have a console here that we punch in the name and do measurements, etc. That's this thing in the back here. We have a ultrasound probe, or the transducer, that's connected with a cord to the machine, and there's a CPU processor that adjusts the information and then displays it in real time on the screen here. So the transducer is a small handheld device. It looks like a microphone. It sends out high-frequency sound waves, so there's special crystals in there called piezoelectric crystals that, when stimulated by electricity, produces sound waves. And these sound waves go through the tissue. Some go straight through, some gets reflected back to different degrees, and the computer can analyze that information and display an image of the breast in real time on the screen there. What will you experience during the procedure? That's painless. There's some people who insist on pressing very hard when they're doing ultrasound and cause patients discomfort. But, I mean, especially if they have very tender breasts, you just have to let the person know that that area is hurting, and they will ease off on the pressure, right? Usually 10 minutes, 20 minutes, the examination is complete, sometimes less. If there's something to look for, like if you have an area of interest, that you're feeling a lump somewhere, or if you had a mammogram that showed an abnormality somewhere, then the examination might take a little bit longer because we're trying to find that abnormality, etc. Sometimes we might be asked to turn to the side, etc., so we can get into certain parts of the breast a little bit better. And when the examination is complete, you're just asked to wait, and sometimes we have to go back in and look if there's an area that we probably need to go back and look at a little bit more carefully. And how is the image created? Basically, these are the crystals in the ultrasound probe or the transducer. It sends the sound waves into the breast, and it gets reflected back into the same probe that detects it. Sends a signal to the computer, and it creates an image that's able to determine how far the object is away from the probe, so the depth, the shape of it, the consistency of it, whether it's solid or liquid, etc. And why do we need the gel? Because these ultrasound waves doesn't pass through air too well. So we need a coupling agent to be able to get rid of the air or eliminate the air between the probe and the skin. So that's why a gel is required. Do you have, what does a normal breast look like? Well, this is the anatomy. You may have seen this a little bit earlier. Basically, you have ducts that lead to the nipple, and the breast is divided into lobules. So that's the gross anatomy. But and you had a feel of how it looks like on a mammogram. But ultrasound, it looks completely bizarre. Like, people often ask, well, that looks like the beach or something like that. It kind of does, but you really have to wonder if we actually making it all up, or we could actually see things in there. But yeah, no, we could see things in there, right? So this is superficial and this is deep. This is the rib, this is the muscle, this is the fat behind the breast. This tissue here is the breast tissue. You notice how some of it is white, some of it dark. That's the fibroglandular elements. The skin line there, and you always have a layer of fat underneath, so we know what we're looking at, right? So this is the tissue that produces the milk. This is the fat behind, and this is the fat in front. What about how do some, so you know what normal looks like? And then another question patients ask, well, how do you know what's abnormal? It doesn't project too well because we light, but these are some of the three commonest things that we might see on an ultrasound, right? So a cyst, as Dr. Suarez would have showed you, is completely black, right? So it's dark or anechoic inside of it, and behind a cyst, it sometimes is a little bit bright. So that's a typical feature of a benign, non-cancerous lesion that's filled with fluid. We leave this alone unless it's bothering the patient, having pain or something, then we might put a needle into it. This and this is a little bit different. You notice how the shape is a little bit ovoid. It's not as bright behind. The margin is still well defined, and it's a little bit more gray. So that's what they call a fibroadenoma, which is a solid lump in the breast, but it's not cancer. Right? So it's not fluid, which is a cyst, but it's solid, but it's not cancer. But how do we know that's a fibroadenoma? I could tell you that is probably a fibroadenoma, but I don't know if that's a fibroadenoma. I could tell you that it probably is, but there's no way for me to know that that is a fibroadenoma unless I biopsy it and confirm it's a fibroadenoma, or you have about 3 of them that look in the same exact way like that and around the same size, or you had that there a while now and it's not changing. And that's the only way for me to know that that is a fibroadenoma. If you come with this and I see it, I say, look, I think this is a fibroadenoma. We could do one of two things. We could either monitor it to keep a close eye on it, or we could biopsy it to prove that is what it is, right? And then we take it from there. It used to be in the past where radiologists were happy to call these things benign and say, leave it alone, there's no need to do anything. That day has come and gone because there are many instances where you see patients who have things labeled as benign turn out it's not so benign after all, right? Then this one, look at this one compared. You know why they call it cancer? You know the horoscope sign, the zodiac sign for cancer. It's a crab, right? This have arms going in all different directions. It's spiculated. It's stellate, as they say. It's hypoechoic. It's really dirty looking and has a rim around, a halo around it. So we're not too happy with this one, and this one is growing in all directions. This one is growing like this one is growing like that. So we do know what we're looking at. We could look at these 3 things and say this one is definitely benign, this one is definitely malignant or cancerous, this one we're not too sure. And then we can use other tools on the ultrasound machine to further characterize lesions. So we can put on what they call Doppler ultrasound. So Doppler ultrasound uses the same sound waves, but we can actually use it to measure the amount of flow. We can measure the direction of the flow, so anything flowing towards the probe is red in this case, so anything flowing away from the probe is blue. So we can put it on, put on that, press a special knob. There's no need to change the probe or anything. You just press a knob, and you're able to tell what is the blood flow in the structure. And the computer collects and processes that information and can display it like this. So this would have been the mass, like what we saw in the previous image. And then we press a knob and we can get the blood flow. And you can see how much blood flow this thing has. So what some researchers have found is that benign lesions, or like the fibroadenoma we saw before, might have about twice as much blood flow as a normal breast tissue. But some cancers have about 5 times as much blood flow. Because if you think about what cancer is just uncontrollable division of cells. And for something to grow and grow and grow, it needs to be fed. It needs a blood supply. It needs new blood vessels to grow in all directions. And therefore, this is what cancer would look like on Doppler ultrasound. At the Cancer Society, we also have special software that we can measure something called the stiffness of the lesion. Right? So that is something called elastography. It's very easy. You just find the lesion, you press a knob, and it tells us how stiff the lesion is, and you could put it on a scale like this. So basically the premise is, cancer is very, very hard, craggy, abnormal, stiff, but benign things like a cyst or fibroadenoma will be more soft. So the more it tends towards this appearance, the more stiff, we assign a score to it, and the greater the chances to be being malignant. At the end of the day, though, we could only say, and Dr. Jargo will know when we can say something, as I will say in my mind that this is definitely malignant and give it a score. And that's why we've standardized the reporting. So we give it a score as to what I think it is. It's highly likely that this is going to be cancer. But you notice the words, highly suspicious for malignancy. It has not been proved. That remains to be proved, right? So we can say something is most likely going to be cancer, and we kind of know in our head that I'm almost sure it's going to be, but we have to prove it by doing a biopsy. And that's where the ultrasound-guided breast biopsy comes in. So now, if you can see something with ultrasound, then you can biopsy it with ultrasound. If you cannot see it with ultrasound, you cannot biopsy it with ultrasound. It's as simple as that. If you could feel it, you could biopsy it by feeling it. If you cannot feel it, you cannot biopsy by feeling it. However, if you could feel it, and if you could also see it with ultrasound, it's better to biopsy it with ultrasound because you can get a better quality biopsy with ultrasound. Because when you do a biopsy, you take pieces from all the different parts of it, so you get a more truly representative sample than if you're just feeling it and putting a needle in. But what about if we can't feel it? What about if we can't see it with ultrasound? Well, then how do you do a biopsy? So that is like the calcifications Dr. Suarez was mentioning, which is an early sign of cancer called DCIS, which we want to pick up before it becomes bigger or becomes a mass. We have to actually use a mammogram machine, find those calcifications and do a biopsy. That is called a stereotactic biopsy, or we put in a little marker for the surgeon to go and remove it. So it takes the whole sample off and sends it to the lab to test. Right, so that's basically the algorithm for managing it. What if you can't see it, you can't feel it, you can't see it on ultrasound, you can't see it on mammogram, but you could only see it on the MRI? Well, then you have to do an MRI-guided biopsy. You have to hook the patient up to the MRI machine and use all kind of fancy things to get a needle into there. And remember, you can't put metal in an MRI machine, so you have to use special equipment and all of that to do the biopsy. Right, so it gets complicated. But the simplest way to do a biopsy is using ultrasound. It literally takes a couple minutes to do, especially if you see the lesion very well. And this is basically how it's done. There's a graph, a diagram that shows you have the mass there, you line it up with your ultrasound, and you put the needle in. The needle comes in from the side so that you could see it along the entire length of the screen. And this is a special type of needle this doctor is using called a vacuum biopsy. So this is hooked up to a powerful suction device here that sucks out large pieces of the tissue, because the more tissue the pathologist has to work with, the better diagnosis he can make. All right. And this is two examples. So this is a cyst and a needle is in there. We can see the needle. And biopsies are almost, people have a fear of biopsies, right? You will feel afraid you're going to get something stuck in your breast, right? It really is not, and most patients after will agree, it's not painful. You feel like you're going to take blood, you feel a little pinch, the area is numb. We numb all the way down, and you could see, watch the screen while we're doing it, you can see the local anesthetic going all the way down to the lesion. And then you see us make a little tiny nick in the skin that you don't feel, and then you see the needle going into the lump, you see the cyst collapsing, and most patients go, wow, at that point. Or you see us taking a piece of the mass, and we take about 3 or 4 pieces, and most patients, 99% of patients, don't experience any pain. The ones who have pain is the ones who are very, very nervous beforehand, right? Quick and easy. And this is what the samples look like. And then the pathologist will look at it under the microscope and say, give it a grade as to whether it's very aggressive or not so aggressive or benign, etc. So what are the common uses of breast ultrasound? There are two categories of uses of anything in radiology. When specifically tonight, we're talking about mammograms and ultrasound, whether it's to diagnose something or screen for something. These things are two different meanings. If you have a lump and you're using ultrasound, ultrasound is being used to diagnose what the lump is. That's different from screening. Diagnosis is trying to characterize an abnormality. Screening is somebody who doesn't have any symptom whatsoever and wants to know if they have cancer or not. And that's what ultrasound can be used for that as well, although mammography is the only validated modality for that. The primary use of breast ultrasound is to diagnose. So as Dr. Suarez was talking about the young lady who had the lump and the doctor said that can't be cancer. Well, she should have had an ultrasound which would have evaluated that physical complaint, whether it be a lump or skin dimpling or discharge or pain. You come and you get assessed and possibly get sent for an ultrasound. It is used to also use when you have an abnormality that shows up on a mammogram. So people will say, well, oh, I have the mammogram already, why do I need to have the ultrasound too? Well, the ultrasound will help further evaluate that. And sometimes even you have the best modality, which shows up everything, which is the MRI, you still need to come back to the ultrasound to have a look at it again and possibly to do a biopsy. And the major role of the ultrasound is to divide up something as to whether it's solid or fluid. Because if it's fluid, it's very, very unlikely that that is going to be cancerous. It can also be, as I was saying before, a screening tool, right? So if you have a very high risk for breast cancer and you have very dense breasts, they tend to recommend an MRI as the best way to screen. But as far as I'm aware, there's no MRI breast available in Barbados. There are one or two places that do it in Trinidad, and I suspect one or two places in Jamaica as well. But it's something that is not very widespread and it's extremely expensive, right? So in those instances, an ultrasound might be considered a substitute, a suitable substitute. If you're pregnant, of course, you shouldn't be having a mammogram during pregnancy. Even though it's a low dose, you probably don't want to get exposed during pregnancy. Ultrasound is a good way to screen. If you're a younger patient, an ultrasound is a good way to screen as well. And what we were alluding to earlier, if you have increased breast density, so if you have very thick fibrous or fibrocystic breasts, ultrasound is very useful to screen in those instances. But what about the question Dr. Jagru initially asked, well, why don't you just do an ultrasound and not do a mammogram? Well, I always tell patients the mammogram gives you an overall idea of what's going on in the breast. Even if you have very dense breasts, you can still pick up abnormalities. And also, mammogram picks up calcifications, which is a little powdery white specks, like little dust that you see on a mammogram. There's no way you're seeing that on ultrasound. And that's a sign of DCIs. That could be a precancerous lesion, which if removed, could save your life, right? If that develops into cancer later on. So there are people who looked at mammogram plus ultrasound. So in other words, you have your mammogram and you follow it up with an ultrasound. You don't have your ultrasound and follow it up with a mammogram. You start off with your mammogram, and possibly it could evolve to something where you get it on the same day right after. So you just come and get both the same time, basically. But with the proviso that the person who's doing the ultrasound quickly has a look at the mammogram, right? And when you do screening, which is when you compare conventional screening, which is really mammogram, and sometimes with the physical examination, to screening with mammogram and ultrasound, there is a much more greater pickup then, a greater sensitivity for breast cancer detection, right? So almost 100%, 97% compared to 74%. Of course, this is one person's data. Another person's data might be lower, right? All researchers have different percentages, but there's a vast difference between the two. So the two of them work hand in hand and could actually complement each other very well. So a little bit of what we're talking about, the physical examination. This is what we find when cancer is picked up by physical examination, meaning they wait till you feel a lump, tends to be at this size, 2.1 cm. Nobody finds a cancer that is less than 1 cm. And you might ask, well, what's the difference? What's the difference if I find it at 2 cm or 1 cm? That's not no big this versus this, right? If it's 2 cm and 3 cm and 4 cm, your chances of surviving this was the reverse of exponential. It's much lower, right? because the chances are it would have spread to the lymph nodes and spread outside the breast. If you get it less than 1 cm, the smaller you get, the better the chances of survival. So that's why, I oftentimes do not discuss results with patients, right? So I do the biopsy, and sometimes that's the end of I don't actually review the results with the patient. I prefer them to review it with the clinician. But the odd cases where I do have to talk to the patient with the result. Of course, you're traumatized. You have this doctor telling you have cancer because you had a 0.5 centimeter lump that turned out to be cancer, right? But what I try to tell them is you actually could consider yourself lucky because you picked up this cancer at such a small size, your chances of living is almost 100%. Whereas if you had waited and kept your head buried in the sand and waited for this to get bigger, your chances of survival would have been 50% 2 years down the road. All right? So, but of course, nobody wants to hear some crazy doctor telling you you're lucky you have cancer in your breast. But if you think about it like that, it is, right? When the cancer is detected by mammography, screening mammography was around 1 centimeter, with 73% of them measuring less than that. And in dense breasts, the cancers picked up with ultrasound is around the same thing. So it's a good modality to use in conjunction with mammograms, but it does not replace mammograms. And in patients with dense breast tissue, ultrasound also has a very good role to play in that the ultrasound and it picks up lesions that are not detected on mammograms. So that case earlier where we just couldn't see the cancer on the dense breast tissue, ultrasound, if an ultrasound was done on that patient, it would have been picked up. So this is a test for you. So look at the white dot. How easy it is to see the white dot here. Everybody can see the white dot here. Think of the white dot as cancer. That's not cancer. That's just a piece of metal that somebody placed. Look at this one. This breast is mildly dense. We could just see the dot, most of us. And what about this one? Unless you look extremely carefully, you're not going to see that dot, right? So it's the same thing with cancer, except cancer is not a bright white dot. It's less easy to see. So imagine if cancer is less easy to see in a dense breast, what trouble you're in. So that's why ultrasound in these patients is very good. Well, what is this breast density we talk about? As I was alluding to earlier, the breast is made up of many different tissues, right? This is muscle here. Fat looks dark on x-rays, and the glandular elements look very bright on x-rays, right? So everybody has a different combination of these. Right, so this patient probably always felt that their breasts were lumpy, right? This patient would not have that same sensation. So this variable combination of fat and fibrous tissue gives you that breast density. And who are more likely to have dense breasts? Well, I find in our population, we are more likely to have dense breasts, right? Women of African descent tend to have greater breast density. Women of younger age, women who haven't reached menopause yet, women who use hormone replacement therapy. You see, this is why you must breastfeed, right? Most people don't like to breastfeed again. This is why you must breastfeed. No history of breastfeeding, you get very dense breast tissue. If you have not a reason to have children, if only to reduce your risk of having breast cancer, right? And having children at older age, again, all of these are risk factors for having. You notice it's the same thing. These are the same risk factors for breast cancer. And what I'm talking about here, what are the risk factors for having dense breast? So dense breast in itself is an independent risk factor for developing cancer. Look at this case. This is the same patient who had mammograms a couple of years apart. And this was the earlier one, and this was the later one, and the density of the breast actually increased, right? Because this patient went on hormone replacement therapy. So some patients cannot handle the symptoms of menopause, so they take hormones to exogenous or outside or hormone replacement to help mitigate those symptoms, and then the breast get a little bit more firmer and thicker, and that is how the breast density can change. So your breast density is not static, it can change. As you get older, it should get less dense, but what we find is this basically almost remains the same throughout life in some patients. Oops. Couldn't figure out how to advance now, advancing too fast now. So this is what a spectrum of the breast density, predominantly fatty, mildly dense, moderately dense, very dense. And it's up to us radiologists to adequately characterize these things, because this patient, compared to this patient, has a much greater chance of developing breast cancer, and they should be aware of that. It went so far as to many states in the US, as has been alluded to earlier, have passed legislation making it mandatory that the breast density must be reported, and it must be stated on the mammogram, and the patient must be made aware that they have very dense breasts, so that they can be informed that they have a higher risk of cancer and they could take other action. Be it, doc, I have dense breasts, I need an ultrasound, or an MRI in some cases if they have other reasons to have an MRI. So patients must be informed of their breast density. Look at this case. This, remember I told you the white is dense breast, so this patient would have a very white looking mammogram. And look at the middle of this white area here. You have this black area that's irregular, spiculated. This thing is like, there's a scale here, this is like less than a centimeter. So in other words, if you had done a mammogram and this patient would be totally normal, happy to say it's normal, come back next year. But the ultrasound showed something in the middle of that dense breast tissue that would never have been seen on a mammogram, right? And that is cancer. So ultrasound in combination with mammogram picks up mammogram. So look at this statistic here. Mammography alone, out of 1,000 women, detected 5.4 cases. Mammography with ultrasound detected 7.3 out of 1,000. So just by adding the supplemental ultrasound, and almost 2 cancers out of 1,000 people were additionally detected. And what is the downside? Well, now you know everything is not perfect, right? What is the downside? Is that, you know that little same dark thing we saw there that we show was cancer? Sometimes when we biopsy it, it's really not cancer. It's just normal tissue or fibrous tissue or a cyst or a fibroadenoma. And you biopsy it because you was worried about it, but it turns out it's not cancer. So that is the downside, in that we're saying this is something that could be cancer, but when we biopsy it, it's not cancer. So that's the only downside. But what is happening as we use the other tools, like the Doppler and the elastography, and we use other different things, we're getting a little better and better and better. Nobody likes to do biopsies for no reason and to get benign all the time. But what we must recognize is to get 10 malignant cases or 10 cancer cases, we might have to do about 30 biopsies, right? So in other words, we haven't reached the point yet, in the future we will, where everything we biopsy is going to be cancer. We still don't know for sure. Like, remember I was talking about earlier, that fibroadenoma, it could still be cancer, but a less aggressive type. But it might reach a point where we develop some imaging modalities that we will to tell you even beforehand that this is almost certainly going to be cancer and could avoid the need for biopsy in certain instances. So with additional experience, the amount of those false positive biopsies should decrease. And Dr. Suarez mentioned automated breast ultrasound is something I talked to Dr. Jagro many times about how it might be a good way to add to the service that she provides, right? And we're thinking about, I made a pitch to the Trinidad and Tobago Cancer Society and they got a quote and they're thinking about getting it. So basically, when I sit there and scan an ultrasound, I'll do an ultrasound with breast or somebody else does, no matter how good we think we are, we're going to be missing things, right? Because that's just the nature of ultrasound. If ultrasound could pick up everything, then we wouldn't even need mammogram, if you think about it like that. It doesn't, right? It's very operator dependent, it's machine dependent. It's a good problem-solving tool, but it's not a very good screening tool by itself, right? This machine scans the breast, much like, you know, those old paper scanners that we have in the office that goes and scans the document and saves it as a PDF. It basically does that. And you have that information now, like a CT scan. You send it online, you come back later and you look at it. You plug it into software, the software will pick out all the abnormalities. You go and look and you see, and you go and look at it the next day, 2 weeks after. And then you say, okay, look, this patient has this, let's bring them back and we'll do an ultrasound, a normal ultrasound and a biopsy of that area. So that has sort of streamlined the way breast imaging and breast screening has evolved, because you could come and get your mammogram and your ultrasound at the same time. You know, you'll have to schedule for this person to be here. And on top of that, it's more accurate as well. So that is how the field has been evolving. So what are the benefits of breast ultrasound? It's widely available, easy to use. It's cheaper compared to the other modalities. It's safe. It doesn't cause any harm. There's no radiation involved. It gives a clear picture of soft tissues. Like, for example, that case where we saw the little tumor in the midst of the dense breast tissue, and it gives you real-time imaging, and that is extremely good for doing things like biopsies. What are the risks? There are no known harmful effects of ultrasound at that strength to cause any harm on humans. Sometimes you have to press, and it's a little uncomfortable in certain patients. The harm comes in this part of it here, having to do procedures that turn out to be benign or not cancer, and also having to call back the patient. Sometimes we say, come back in 6 months and we'll check and we'll see. It's easy for us to say that, come back in 6 months and we'll see. But they might have the odd patient who gets extremely nervous now. They can't function. They think they have this thing in the breast and it's going to turn to cancer and all of that. That's not necessary, right? The reason why we say 6 months, that is an international figure that is used. Very few people has such an aggressive breast cancer that in 6 months, it has changed so much that it altered the prognosis, right? So that's why we say 6 months is a safe period. If in 6 months it come back and it grew a little bit, looking a little different, well then, okay, we biopsy it or we remove it or whatever. But that is not going, that time frame is a short time frame. It's not going to change your prognosis, right? It's not 6 years, it's 6 months, it's a short period, right? And I'm going to finish now, just 2 more slides. And the risk of being false positive is the biopsy issue we were talking about. So what is the current ACR, or American College of Radiology, recommendation? They put out something again last year, which is less than a year ago. Annual mammography. To avoid the confusion, a lot of people have been bashing mammograms, right? 40 years and older. So forget about what some people say, 50 years, some people say every 3 years, it's confusing, right? I like simple, 40 years, every year, everybody, right? If you have a higher risk, well, then you consider starting younger. If you have some additional risks, especially if you have dense breast tissue, which you should be informed of, you should add ultrasound. And they use a term, may be appropriate. So if you're 40, you should be having annual mammograms, as long as you're able to do so. If you have dense breasts, you should be having annual mammograms plus an ultrasound every year. If you have predominantly fatty breasts, you can just do the mammogram alone. All right? So in conclusion, women with dense breast tissue are encouraged to discuss that fact that they have dense breast tissue. So if you know you have dense breast tissue, you can't change that. That's the way you were born, right? That's your genetics. Diet, exercise, eat colorful fruit and vegetables, stop smoking, stop drinking alcohol. If you do those 5 things, you reduce your risk of cancer by 35%. Right? Very easy to do those 5 things. Don't drink too much, stop smoking, exercise, eat colorful fruits and vegetables, have a healthy weight, stop smoking. Right? So screening. So if you know you have dense breasts, you want to reduce your risk of cancer, you do those things in addition to having regular screening, right? Screening ultrasound has been shown to increase the rate of cancer detection when you combine it with mammography. So get your ultrasounds after you have your mammogram. The downside, knowing fully well though that the downside of it is sometimes the doctor picks up things on the ultrasound that he might have to biopsy. He or she might have to biopsy that turns out that is not really cancer. That's the only downside to add supplemental ultrasound. Right? And then it might be the solution to add automated breast ultrasound to the picture to be able to reach a greater amount of people and hence pick up more cancers at an earlier stage. And the whole point of screening and picking up cancers at an earlier stage is that when you treat it, you get a better outcome than if you wait for it to be bigger. Right, so that's it.